Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr.
Jamila bin Adi. I'm a consultant internist in Dubai Health Authority at Rashid Hospital. It gives me a great pleasure to chair this session tonight about the guidelines for the management of hypothyroidism, which will be presented today by Dr. Alauddin Bashir, who is a consultant internist and endocrinologist in Dubai Health Authority at Dubai Hospital. Dr. Ala will take you through an interesting presentation with regards to the management guidelines of the hypothyroidism. So welcome, Dr. Ala.
Thank you very much, Dr. Jamila. I'll start sharing my, I'd like to welcome everyone here. And today we are going to discuss a topic that I thought it's common and simple. And I hope that every one of you would, inshallah, enjoy the presentation. My talk is basically about guidelines for management of hypothyroidism. And I thought the best way to start this presentation is by dividing the roles. We need to know what's the role of an internist or a family physician, and what's the role of the endocrinologist before we proceed with the presentation. So what is the role of the non-endocrinologist in management of thyroid disorders? I believe that, and I always say it to whoever attends the clinic with me, that management of hypothyroidism doesn't usually, or in most of the cases, requires an endocrine attention, because physicians who are familiar with the diagnosis and treatment of hypothyroidism should be able to treat and care for patients with hypothyroidism in most of the cases. And we leave only specific groups of patients for the endocrinologist to deal and handle. And those are basically the children and patients who are very difficult to maintain them into the euthyroid state. Pregnant ladies, if there are nodules in association with the hypothyroidism, or if there is any other issues associated with hypothyroidism. And here that brings me to specific, we know that if a patient is having hypopituitarism, will be having as well a central hypothyroidism. Patients with Addison disease might have autoimmune Hashimoto thyroiditis. Patients with diabetes sometimes might have hypothyroidism. So if they have an associated endocrine problem, then probably we can refer to endocrinologists to deal with them. And if the patient had sort of abnormal thyroid function that are difficult to interpret, and we'll go through some abnormal thyroid function test as we go with the presentation. So just to take you a step back, because the most common cause of hypothyroidism is Hashimoto thyroiditis. And Hashimoto thyroiditis is basically an autoimmune disease due to anti-thyroid peroxidase antibodies. And I put this exactly to show you what's the function of the thyroid peroxidase antibodies and what does it do in the synthesis of thyroid hormone. If you go through these steps, and these are the steps of thyroid hormone synthesis, I want you to look from step 3, where we start, where there is an oxidation of the iodine, where we have iodide that will be oxidized to iodine. And for this step, you need the thyroid peroxidase as a cofactor or a helping enzyme to do this oxidation. The next step, which is 4, which we call it organification, where the thyroglobulin molecule is being organified by the iodine to form monoiodothyronine and diiodothyronine. So this is the organification. Again, you need the thyroid peroxidase for this step. And the 5th step, which is the coupling of the monoiodothyronine together to form diiodothyronine, or di with mono to form triiodothyronine, or even T3 or T4. That's again a step that requires peroxidase. So we need the thyroid peroxidase for more than 3 steps probably in the synthesis of thyroid hormone. And if we have antibodies against the antithyroid peroxidase, then we will have defect in thyroid hormone synthesis, and definitely it results in hypothyroidism. So how common is thyroid disorders or hypothyroidism? The American Thyroid Association states that more than 60% of patients with thyroid disease are not aware that they have hypothyroidism. And that's why they do recommend screening a specific group of people for thyroid dysfunction. For example, if you have a patient, even if you are asymptomatic, who presents, for example, with sinus bradycardia to the ER, then those are people who need to be evaluated and tested for thyroid hormone function. They also recommend that serum TSH should be done at the beginning from age 35. Every 5 years, frequently, you need to do a thyroid function test, which is a TSH, to detect presence of hypothyroidism for even normal and healthy people. So who exactly do we need to screen? And I looked at different guidelines here that tells you which group of people we need to screen. And why do we need to screen them? Now, I'd like to say we need to screen people with thyroid because hypothyroidism is not just a thyroid disorder. Hypothyroidism is associated with significant cardiovascular risk that comes from different areas. One of them, hypothyroidism is associated with increased atherosclerosis, aortic atherosclerosis. Hypothyroidism is associated with increased homocysteine level. Hypothyroidism is associated with increased lipoprotein levels. Hypothyroidism is associated with increased lipid profile, total cholesterol, and LDL levels. So all these factors actually predispose to cardiovascular disease. And if we look at these graphs from the Rotterdam study, where they looked at patients with hypothyroidism, they brought normal people, euthyroid people with subclinical hypo and not frank hypothyroidism, and patients with hypothyroidism. And a fourth group was patients with hypothyroidism with positive antibodies, and they looked at their cardiovascular risk. And if you look at the graphs, the euthyroid is the group of people we compare with. And if you look at the subclinical hypothyroidism, the risk actually increases by 70%. So the relative risk increases to 1.7. That's around 70% more than normal people. And if they have antibody positive, it goes to 1.9, the relative risk of development of the odd ratios actually for development of aortic atherosclerosis and cardiovascular events. And if they have antibody positive, then the risk increases in subclinical hypothyroidism to 2.3%. And if they are frankly hypothyroid with positive antibodies, it goes to even higher level. So as I said, hypothyroidism per se is associated with increased cardiovascular risk. If you look at another study done by Canaris, that was a long time ago, he looked at the association of TSH levels with lipid levels, and specifically they looked at total cholesterol. So if you look at this graph, the higher the TSH level, the higher the total cholesterol level. And that indicates a significant correlation between total cholesterol, between TSH and total cholesterol. And this has been proved by the fact that if you treat hypothyroidism with thyroxine then the cholesterol levels drop. And that has been reflected again later in the guidelines, where they say if you have a patient with hypercholesterolemia, then probably you need to, those patients with hypercholesterolemia, you need to evaluate them for hypothyroidism. And if they are hypothyroid, sorry, and if they are hypothyroid, you might need to treat them with levothyroxine before you start statin therapy. Again, as I said, hypothyroidism is associated with an increased or elevated lipoprotein A levels, and that definitely we know has an association with an increased cardiovascular risk. And this is a study done by Kung et al., where they looked at the lipoprotein levels in patients with subclinical hypothyroidism with a control group. And they found a significant elevation in lipoprotein A in patients with subclinical hypothyroidism when they compare them to normal controls. So that proves again, hypothyroidism is associated with increased cardiovascular risk. And again, we know, in the literature, we don't usually measure the homocysteine level, but we know that increased homocysteine level is a predictor of cardiovascular disease or a risk for coronary artery disease. This is a study that looked at the correlation between the TSH level and the homocysteine level. And they found that there is an increase actually mortality in patients with homocysteine, and they found that patients with hypothyroidism has an increased homocysteine level. So if we need to screen those patients, whom should we screen? The guidelines, these are multiple guidelines actually. The American Thyroid Association and the American Association of Clinical Endocrinologists, the National Cholesterol Education Program, the NCEB, Panel 3, they all recommended that a patient with dyslipidemia should be evaluated for or should be tested by TSH level. And if they had an elevated TSH, you need to start them on thyroxine before even starting statin therapy for them. So number one of the group of people we need to screen are patients with dyslipidemia. The American College of Cardiology and American Heart Association do suggest that thyroid function test has to be measured in any patient with coronary artery disease risk. So again, if they have an increased risk of coronary artery disease, measure their thyroid function, and if they're hypothyroid, then probably you need to treat those patients. The American Diabetes Association, and this is obvious, that all patients with type 1 diabetes, because it's an autoimmune disorder, you need to evaluate for or screen for hypothyroidism in those patients. And patients with type 2, only if clinically indicated. The American Association of Clinical Endocrinologists do recommend screening patients with depression for evidence of hypothyroidism, because it has been found that patients with depression, a good number of them actually do have hypothyroidism, and when you treat hypothyroidism, then their depression improves. That is on one side. From the other side, many medications that are being antipsychotic medication do affect the thyroid function test. So you need basically to evaluate or take a baseline thyroid function test when you treat those patients. And this is the idea or the relation between thyroxine and depression. It has been found that thyroxine therapy has been recommended in patients with depression who has persistently elevated serum TSH. And that antidepressants may be less effective if the thyroid function test has not been normalized. So we need to normalize thyroid function test to see whether our treatment with thyroxine is effective or not. And this point also, people who come with infertility, any lady who comes to you seeking fertility, thyroid function test is one of the very early tests we do for them. Correcting hypothyroidism or elevated thyroid function, even sometimes at the upper part of upper normal, TSH upper normal, that improves their fertility. So the recommendation is that any patient with infertility should be evaluated with a thyroid function test. Hypothyroidism has to be treated. If patients are even subclinically hypothyroid and not frankly hypothyroid, they have to be treated to normalize their thyroid function test. And that has been found to improve their fertility. So how does a patient with hypothyroidism present? As you know, hypothyroidism does affect almost each and every organ in the body. So the usual presentation might involve a cardiovascular disease, central nervous system. It can present with GI manifestations or even skin manifestations. So in the cardiovascular system, it's associated with decreased ventricular contractility and reduced heart rate. They might present with bradycardia. And if you look at the effect on blood pressure, you might find an elevated diastolic blood pressure. The effects on the nervous system might present with decreased concentration. And that decreased concentration actually will be interpreted by patients as, you know, I'm being more forgetful, I'm unable to concentrate. That's the usual complaints. And if you don't concentrate, you don't record, so you will not remember. So it's probably memory lapses. And they might present with depression. They might present with constipation as well. And in the musculoskeletal system, a good number of them might present with myalgias and fatigue and cramps. And some of them, when we examine, might have a delayed ankle jerks. They might present with some lower limb edema due to decreased GFR. And as I said, they might present with menorrhagia, infertility, and anovulation. And they might present with high cholesterol levels as well, and high LDL compared to triglycerides. And in the skin, which is the most common presentation, is hair fall, dryness, and coarseness of, and having coarse hair and alopecia. And some might present with loss of scalp hair and even the lateral aspects of the eyebrows in severe hypothyroidism. So this is just an introduction, a quick introduction to hypothyroidism, when to screen and whom to screen. Now I'm going to present a case, take you through the management, and take you through the guidelines of hypothyroidism. So this is a 41 years old female who attended the clinic complaining of progressively increasing fatigue, lethargy, hair fall for a couple of months before she arrives to your clinic. She doesn't have any other symptoms, no other constitutional symptoms, and she's non-hypertensive for 1 year, but she's very well controlled on ACE inhibitors. She had a past medical history of gestational diabetes 4 years ago, and that was managed only on diet. Since then, she was not started on any anti-diabetic medications. She takes vitamin D supplements regularly, and she has a family history of diabetes and hypertension in her father. Clinically, she was alert, stable, her pulse is normal, 82, blood pressure normal, 125/80, temperature was normal, and weight was normal for her, and her BMI actually is normal. Clinically, when we examined her, there was no goiter and no tenderness, and there were no eye signs, but she had a dry skin, and systemic examination was grossly normal. And these were basically her thyroid function tests. Her T3 was 2.4, her T4 was 6.2, and these were significantly lower than the normal range. The normal range, as you know, for T4 is 11.5, and her T4 is only 6.2. And T3, the lower range is 3.5, and her T3 is 2.2. while her TSH is 150. Anti-thyroid peroxidase antibodies were requested for her, and they were significantly elevated. The positive range was more than 25, and her ATPO was 160. Her thyroglobulin was normal, anti-thyroglobulin antibody. So how do we interpret thyroid function tests? I think it's very essential to look, usually when we interpret thyroid function test, we look usually at TSH and we look at T3. This is at T4, sorry, TSH and T4. Maybe recently you have noticed that in the thyroid function test panel, T3 has been withdrawn. It has been done with actually in Salama. If you request a thyroid function test, you will find only TSH and T4. And if you want T3, you have to request it separately, basically because we don't need T3 for diagnosis of hypo or hyperthyroidism. We need to look at TSH, and if it is abnormal, then we look at T4, and based on that, you can interpret the results and decide whether you need to do a T3 or not. So I'm just going to show you a quick graph that actually tells you about interpretation of thyroid function test based on TSH level and T4 level. Now, if this is a 9-box, these are 9 boxes. At the center of the box is euthyroidism, which reflect, if you look down, is the normal TSH, it's either low, normal, or high TSH. And on the left side is the T4, either low, normal, or high T4. So you need to look at these boxes based on where is normal TSH and where is normal T4, then that gives you euthyroidism, where they meet. So in cases of hypothyroidism, you will have high TSH and low T4. And that's exactly what this patient has. This figure actually is very helpful for people while they're doing their usual practice to remember, if this is like this and this like this, then this patient either have secondary hyperthyroidism or hyperthyroidism on non-thyroidal illness, or treatment with thyroxine. Is it subclinical hyper? Is it subclinical hypo? So this is very helpful. And I guess if you keep an image of it, it will help you during your practice. So in this patient, the patient has high TSH and low T4. So this is a patient with hypothyroidism, primary hypothyroidism. So as we said, the diagnosis is primary hypothyroidism. What is the next step? And is this enough? I mean, just putting this TSH and T4, are they enough for diagnosis of hypothyroidism, or do I need to proceed and do further tests? Now, the questions we have here, to me, this is a case of hypothyroidism due to autoimmune thyroid disease, which is Hashimoto thyroiditis. But my question is, for all of you, do we need scoring systems? There are a couple of scoring systems that has been developed to diagnose hypothyroidism. Do we need it to diagnose hypothyroidism? Do we need to test the T3? And how are we going to diagnose central hypothyroidism? So I'm going to answer these questions actually from the guidelines, and I'm going to put the guidelines with the evidence, with the level of evidence that you can see. Now, for diagnosis of hypothyroidism, we diagnose hypothyroidism if we had a patient with a TSH level that is more than 10. Okay? And if the patient had a level of TSH more than 10, then this patient has to be considered for treatment with thyroxine. And this is a grade B evidence. Now, if the serum TSH, for central hypothyroidism and patients with pituitary disorders, serum TSH is not actually helpful. We should use actually T4 for evaluation and diagnosis of secondary hypothyroidism. And I would like to remind you what I have said earlier, that having a TSH level more than 10 increases the risk of heart failure. And that's why if the TSH is more than 10, we should consider patients for treatment regardless of their T4 level. Remember, if the TSH is more than 10, you can consider your patients for treatment with levothyroxine regardless of the T4 level. Now, we don't need to test the T3 to diagnose hypothyroidism. So testing the T3 is a waste of money. And this is a very strong evidence. T3 should not be done to diagnose hypothyroidism. We don't need any clinical scoring system for diagnosis of hypothyroidism. Now, as a clinician, you might think of, okay, I need to check the patient clinically, I need to have a goiter, I need to have delayed ankle jerk. Even these clinical signs are not required for diagnosis of hypothyroidism. Diagnosis of hypothyroidism is basically based on a TSH level that is high and T4 level that is low, or TSH level more than 10. I consider my patient as hypothyroid. So the guideline says tests, clinical tests such as reflex relaxation time, cholesterol level, muscle enzymes should not be used to diagnose hypothyroidism. We don't need these to diagnose hypothyroidism. In patients with central hypothyroidism, we need to assess T4 and not TSH to diagnose hypothyroidism. And TSH, and this is very important, measurement in hospitalized patients should not be done routinely because of non-thyroidal illness, which does affect your thyroid function test. I want to explain this here in a bit of details. Now, non-thyroidal illness, actually we get a lot of referrals to endocrine because of a thyroid function test that has been done for a very sick patient. And we always say, if your patient is very sick, don't test his thyroid function. It will definitely come abnormal. Now, the words I would like to say here about non-thyroidal illness, that sickness and illnesses and severe illness are actually considered a catabolic state. And the body will try to preserve itself by reducing the catabolism. If you have normal thyroid function or high T4 in a catabolic state, that will increase the metabolic rate and that will increase the catabolic state. What the body will do, our bodies are really smart. They will try to reduce the catabolic state by first reducing the active form of thyroid hormone, which is T3, and that's the first one to drop. And if the patient is still very sick and his sickness continued for a longer period of time, then T4 will drop. And if the patient is still sick, then TSH will drop. And you might have a picture that is very suggestive of central hypothyroidism, low T3, T4, and TSH. It's very important to note that, it starts with T3, then T4, then TSH. It's very important to note that when a patient reaches a level where TSH becomes low in a non-thyroidal illness, that gives an idea about the prognosis of those patients. Usually they don't do very well. And it is associated with the worst prognosis of that illness. So please don't request a thyroid function test for patients while they are in hospital, specifically or especially if they are very, very sick. So the next step after diagnosing hypothyroidism is to treat them. And the treatment is basically with levothyroxine. And when we try and start treatment, we have specific goals. The first goal is to achieve normalization of TSH levels, and we need to avoid over-treatment by causing subclinical hyperthyroidism or thyrotoxicosis. And this is a very strong recommendation because, again, we frequently see patients who are over-treated and they do present with a suppressed TSH level because of thyroxine replacement. So now, what would the guidelines say for treatment of hypothyroidism? And this is basically the American Thyroid Association guidelines. And it says that patients with hypothyroidism should be treated with thyroxine monotherapy. Only thyroxine monotherapy. There are many people who goes here around and say you can add this and add this, but the guideline says hypothyroidism should be treated with thyroxine monotherapy. And the guidelines does not support use of any other medications with thyroxine. They don't support using the desiccated thyroid hormone or selenium or T3 in combination or any other medicine. Again, guidelines would say only thyroxine monotherapy. So what's the dose of thyroxine? The dose usually, the guideline would suggest starting with a dose of 1.6 microgram per kg. The dose actually range between 1.2 to 1.6 microgram per kg. For patients with thyroid cancer, we might go for a higher level, that is 1.7 to 2 microgram per kg. But for hypothyroidism, the treatment, it ranges between 1.2 to 1.6 microgram per kg per day. This is a daily dose. Now, in patients with coronary heart disease or patients with arrhythmia, we can usually start with a smaller dose. We can start with 25 microgram per day, and then we increase it gradually, and we monitor for symptoms of angina or chest pain. So for this patient, she has been started on thyroxine 125 microgram per day. And these were her results after 2 months. Her T4 was normal, 13.8, and her T3 was 4.4, and TSH is still high. Her TSH is 10.4. So what comes to your mind here? Is it inadequate dose, or what would you do? I just want you to have like 10 seconds thought. What comes to your mind? It's very important. It's very important when you prescribe thyroxine for a patient with hypothyroidism to assess. Most important thing to assess is non-compliance. You might prescribe the medicine and the patient will go and they will not take it on daily basis. They might take today, skip it. So non-compliance is really essential to check. But it's important as well to check compliance with your instructions. I believe when you prescribe this patient thyroxine 125 microgram, you do not send the patient without giving him specific instructions with regard to the use of thyroxine. This is very important. I'll tell you why. Thyroxine requires an empty stomach for better absorption. And even in the best conditions, you get only 70 to 80% of your thyroxine dose that is being absorbed. So you need to give at least 4 hours before the tablet. So that's why we advise patients, take it first thing in the morning on an empty stomach and don't eat or drink for at least 40 minutes to 1 hour after the tablet. And make sure that you don't take any other medications that interfere with thyroxine. What are these medications? These medications are basically the calcium, the iron, because they actually do interfere with absorption of thyroxine. And this is very, very important. If your patient didn't follow these instructions, probably they will come back to you with an abnormal thyroid function test. And then you might need to increase the dose, and probably you're giving then your patient a dose that they don't require, a higher dose than normal. So the absorption of thyroxine actually occurs in the jejunum and the ileum. It requires an acidic pH in the stomach. And as I said, only 70 to 80% under these conditions of thyroxine is being absorbed. Now, it's important, if you have your patient being treated and he comes back to you with an abnormal thyroid function test, to make sure that the patient doesn't have any form of malabsorption. And now there are specific recommendations from the guidelines. The guidelines would suggest that thyroxine should be taken consistently before breakfast or at bedtime, but 3 hours before that they shouldn't take meal. And it is also recommended that whenever feasible, thyroxine should be taken separately from other potential interfering drugs, as I said, as calcium carbonate and ferrous sulfate. Usually you need around 4 to 5 hours. If you take the thyroxine in the morning, you give calcium or iron supplements probably 5 hours after that. In patients in whom the thyroxine dose requirements are higher than expected, we need to look, as I said, for other abnormalities like even H. pylori related gastritis or atrophic gastritis or even celiac disease, because malabsorption might interfere with the absorption, or these are malabsorptive syndromes where you get where it affects absorption of thyroxine. Again, very important, very essential, patients should not switch from different brands of thyroxine. We have thyroxine by Merck, we have thyroxine by GSK, we have thyroxine from different companies. If your patient start on a specific brand, they have to carry on with that brand. Sometimes a change from one brand to the other would result in abnormal thyroid function tests. So you need to check with your patient. Did you change the brand or not? And this is important because sometimes you might start doing a lot of investigations and only changing the brand solve the problem. I'll just tell you a short story of one of our patients who actually had persistently elevated TSH of 100. And then that patient actually, we always thought of non-compliance. We even asked her husband to make sure that she takes her tablets regularly. And he said, well, I'm not available at home all the time in the morning, I do night shifts. Then we actually gave her all the dose once in a week, and we asked him to monitor her, and he was monitoring her, and he was 100% sure that she's taking her tablets. Then we admitted her to hospital. We directly observed her taking her thyroxine in front of the nurses, and her TSH was still high. So what we did at the end is we evaluated her for malabsorption 4 and 4 and 4. We at the end just changed the brand of thyroxine, and we found significant improvement in her thyroid function test. So this is just a story to emphasize on the importance of not switching between different brands, specifically if your patient is, or especially if your patient is well controlled on whatever thyroxine he's taking. Now, there are certain medications, once you start, you need to monitor the thyroid function test. And these are basically the estrogens or androgens. If a patient started on contraceptive pills or a patient started on testosterone injections, for example, then you need to monitor their TSH levels. Specific medications that are either enzyme inducers or inhibitors like tyrosine kinase inhibitors, anti-epileptics, these are significantly does affect the TSH level. And once you start your patient on any of these medications, while on treatment with thyroxine, you need to monitor their TSH level. And this is a very strong recommendation. There is no enough evidence to suggest, and that I have said it early, or to support the use of selenium in patients with hypothyroidism. At the end of the day, many patients actually do insist in starting selenium, and we do allow them because at the end, it's not going to harm them, and there is no much of reported benefit out of selenium. So this is the patient after ensuring that she started using her thyroxine the proper way. She came back on the same dose with a normal TSH level. Now, the guideline recommend after having a normal thyroid function, you basically need to follow them every 3, probably sometimes to 6 months to check their thyroid function. And in UK, they do actually suggest annual evaluation of TSH level. But the shortest period between one test and the other, specifically the TSH, is actually around 6 weeks, 6 weeks to 2 months. So I'm just taking you to one of the few slides left. And because this is a very common question, when to treat subclinical hypothyroidism. And subclinical hypothyroidism is when a patient has high TSH, less than 10, with normal T4 level. And patients with subclinical hypothyroidism who are basically less than 65 years and TSH less than 10, but have severe symptoms that are suggestive of hypothyroidism can be started on treatment. If they're having a subclinical hypothyroidism, but TSH level is more than 10, even if there are no symptoms, you should consider treatment. And if they had persistent subclinical hypothyroidism after hemithyroidectomy. Sometimes patients post-hemithyroidectomy might have a subclinical hypothyroidism for a short period of time. Then the other half of thyroid will actually take over. But if they don't and they continue to have subclinical hypothyroidism, you might need to start them. If you have a patient with persistently elevated lipid concentrations or patients who are planning fertility, then we should actually consider treating them with thyroxine. And that was my last slide. Thank you very much for your attention. And I'd love to have more questions so we can go on with the discussion. I think if no questions later, then I might ask some questions and look for the answers in the answer question and answer part. Thank you very much.
Thank you very much, Dr. Ala. You're having some questions here, and I would start with the first question here. Is the starting dose to treat subclinical hypothyroidism when it's indicated the same as for the overt hypothyroidism of 1.6 microgram per kg?
Actually, That's a good question. Actually, excellent question. Um, when treating subclinical hypothyroidism, we might not need to start the same high dose of hypothyroidism. Some guidelines do suggest starting with a dose of 25 or even 50 microgram. A very good number of patients actually do respond to this dose, and we don't need to go for a higher dose. So usually, uh, if, for example, TSH is only 5 or 6, we start with 25. If it is the higher range, 9 or so, we might start with 50. But we don't need to go for, 1.6 microgram per kg.
Okay. There is another question here which says, what about the patient with bariatric surgery or short bowel disease? Is thyroxine also affected by the absorption?
We have seen actually a couple of cases where patients did bariatric surgery. Actually, bariatric surgery has two effects or two different effects on thyroid function. There are many reports that when patients lose weight due to bariatric surgery, their TSH improve if they have subclinical hypothyroidism, and if they are overtly hypothyroid, their thyroxine requirement will drop. It becomes less than what they were taking before. But on the other hand, having a short bowel syndrome, the absorption usually in the duodenum, and if you do bypass, you might affect the area of absorption or divert the flow of food from the area of absorption, and that might result in some sort of increase in the TSH level. In such cases, you might need to increase the dose of thyroxine as well. But the general rule, what we see commonly in patients with bariatric surgery is an improvement in TSH, but absolutely bariatric surgery can affect the absorption of thyroxine.
Okay. Dr. Ala, there is a question here which is about patient 60 years old, normal thyroid hormone and obesity and slow metabolism. Could this patient take a small dose of thyroxine to reduce weight?
Actually, we don't recommend using thyroxine for weight loss. There are actually many, thyroxine, especially in people 60 and above, might be associated with an increased risk of arrhythmias, especially if they have a normal TSH. When you give them thyroxine, you're going to drop their TSH. Maybe they might go into subclinical hyperthyroidism, and that might result in arrhythmia and atrial fibrillation. So we don't advise starting on thyroxine for weight loss. For weight loss, there are so many other medications that can be used for weight loss. But if there is no indication for thyroxine, we don't recommend using thyroxine.
Okay. Another question. Is there any role for T3 testing and its replacement in hypothyroid patients who are still symptomatic despite normalization of TSH and T4 on levothyroxine?
Well, this is again an interesting question. This is an area of controversy. For many years, the guideline has been, they just always say treat hypothyroidism with monotherapy, and they never recommended using a T3 in combination with T4 to treat hypothyroidism. But recently, in the last maybe 1 year or 2 years, there were a lot of publications on the combination of T3 and T4. Actually, there was in 2019, there was a consensus between the American Thyroid Association and the European Association of Endocrinologists, where they looked at all the literature published on the combination of T3 and T4. They found that there are many studies out, but they tried to grade the level of evidence in these studies. And unfortunately, they found the studies are not mostly strong enough to suggest the use of T3 with T4 in combination. But they noticed that in all studies, patients report improvement in their symptoms when you combine T3 to T4. So probably, and there is a paper published maybe 3 months ago with a consensus that you can use T3 with T4 until a new guideline comes. And that was again from, I think, American Thyroid Association. But they said if you use T3 with T4 combination, you might have problems in interpreting T3 levels because it has a shorter half-life. You might have a problem with interpreting TSH level. And how much is the dose that again, and how much you give from T4 and T3, again, that is something not yet approved and not agreed upon. So there are a couple of issues, but people are considering probably the combination in the near future. I would probably expect the next guideline would suggest using a T3 with T4, but until now and currently, there is no guideline that suggests using T3 and T4 together.
Okay. There are so many questions here about thyroid and pregnancy, but I think we should have like a separate session for this, especially the target TSH, how to treat it. I think this should be a different topic to talk about.
Yes, I would just probably put 2 or 3 points in thyroid in pregnancy. It's very essential to treat hypothyroidism in pregnancy because hypothyroidism in pregnancy is associated with worse, probably pregnancy outcomes and sometimes even fetal outcomes. And if you don't start normalizing TSH level before pregnancy, then that might affect the fertility itself. And I have said in my presentation that if you have a patient with infertility, we have to screen for hypothyroidism and we have to treat hypothyroidism in those patients. So we treat hypothyroidism during pregnancy. Our target is, if I would like to set a target all through pregnancy, is to keep a TSH level below 2.5. But generally the guideline says in the first trimester, it has to be less than 2.5, second trimester 3, third trimester again 2.5. So I would rather maintain a TSH level below 2.5, and the lower the better. If I can go to below 1 is even better. And the treatment again, thyroxine alone, no combination therapy.
Okay. There is a question here about one of the colleagues asking about a good practice. Is it good practice to have a patient, for example, take 125 microgram of thyroxine for 5 days and then 100 for 2 days?
Yes, basically this actually we do it frequently in the hospital, basically because sometimes it's very difficult to, let's say I have a patient and I'm going to treat this patient with thyroxine 125 microgram. If I treat him with 125 microgram, then probably he will come to me with hyperthyroidism or subclinical hyperthyroidism. If I give him 100, he will come to me with a high TSH. We don't have, like in US or in Europe, you go to the pharmacy and you tell him, okay, I need 112.5 microgram of thyroxine. They'll make the tablet and they will give you. But we don't have this actually here. So what we do is we balance, like give 5 days 125, or let's say 3 days 125 and 4 days 100, trying to give him 112.5. Okay, and that works basically because thyroxine has a long half-life. The half-life of thyroxine is almost 7 days. So we can mix, give 1 day this and 1 day this, aiming at those intermediate dose between the two doses, whether 125 or 100.
Okay.
Just
There
give me
were,
a minute, I'll plug my. Yes. Okay, I'm just plugging the.
Dr. Ala, there was a question of relation of hypothyroid also with psychiatric illness. I mean, the question is either depression or in general. Does if the hypothyroid related psychiatric manifestations, would that resolve by treating the thyroid, the hypothyroid or not?
Usually, there will be an improvement in symptoms of depression when you start thyroxine, and even medications, antidepressants work well when the thyroid function test is normal. Yes, there will be an improvement in depression symptoms if you treat hypothyroidism. And basically, severe hypothyroidism per se does lead to depression.
Okay. There's still many questions. I don't know how much time are we left up with. I think probably if there is a place for one more question. Okay. Yeah, there is here a question about regarding fitness for surgery for patients with subclinical hypothyroidism or primary hypothyroidism. What is the safe TSH level prior to surgery?
That's again a very good question. There are a few papers actually published on the safe TSH levels prior to surgery. And actually we would worry about high TSH levels because of reduced metabolism, and that might prolong the recovery period post-operatively. So if the patient had mild TSH levels, mildly elevated TSH levels, like a TSH below 10, sometimes you go up to even less than 20, we might allow the surgery if it is urgent surgery or emergency surgery. If the patient is going for an elective surgery, we preferably delay the surgery until the TSH level normalize. But if it is an emergency surgery, we'll probably allow the surgery, and we make sure that the patient takes their thyroxine prior to surgery. Okay. But you will not find a specific recommendation for a specific safe TSH level that below which you can allow patients to go for surgery. But generally, we practice here, anything below 20 is fine, you can go for surgery.
Okay. I think it's about time now to conclude. There are so many questions still there, but I don't think that we have enough time to answer all these questions. But I think there is a demand on having a session for thyroid and pregnancy, which we might consider, inshallah. And just to conclude, I would like to thank Dr. Ala for this interesting presentation, and would like to thank the audience also for their questions. And I'm very sorry that we cannot take all these questions, but probably we might have few sessions in the future also in this regard. And thank you very much, Dr. Ala, for your lecture.
Thank you very much, Dr. Jamila, and thank you for inviting me to give this talk. Thank you.
Okay. Okay. Thank you very much. I think we'll conclude here.